via the Zoom or Instagram or wherever you are. It's a pleasure to be with you. So I do practice just outside of Nashville in Franklin, Tennessee at the Bone and Joint Institute. And you can advance and just follow me along. I assume if you'll advance faster, I just need to speed up. So these are my disclosures. You know, really what we're going to talk about today is we're going to try to simplify the discussion around robotics and evaluate some of the literature to determine what in the world is robotics really. And I hope you leave this talk with some good things to think about. You know, the demand for hip and knee replacement is exponential. It's increasing. So are revisions. And we as surgeons want to do it right the first time, do it perfect the first time. Maybe robotics can help to minimize that revision burden. So what is robotics? This is the first question. It's actually Aristotle who described robotics first way back in 320 BC. You can see the quote there. I'm not very smart, so I'll skip the words. Let me show you this picture. The first functioning robotic system that we think existed was by Leonardo DaVinci. No shock there. Apparently, this robot could independently serve a drink and salute the visitors. Or maybe when you think about robotics, you think about something like this. You think about Asimo, and you know these guys, incredible technology here. They can play soccer. Or maybe you think like this. Maybe you think future state and like, oh, the robotics are going to take over the world and surgeons are going to disappear. Now, you may want that, but that's not going to happen. I would tell you robotics is perception connected to action. And here's what I mean by that. So, you know, we say robotics, but the reality is we have to talk a little bit about custom implants versus custom surgery. You'll hear people talk about custom implants, and maybe in our Q&A we can talk about that in more detail. But custom implants are formed just for one particular patient. But the concept with robotics very often is customizing the entire surgery. So not only the implant, but how the implant fits inside to the patient. They can be image-based. There's a couple of clicks here, but you can see several systems are image-based, meaning you need a CT scan or MRI before, and several are image-less. You can just advance through this. I think we have a picture of some. Yeah, they can be passive, so they kind of do the work for you versus active. They actually work without the surgeon. One more click shows you that most of the robotic systems in orthopedics are semi-active, means the surgeon has control of the robotic platform, but the robotic system is increased guidance, if you will, and protection for the patient, and again, guidance for the surgeon. So there are a lot of ways to think about robotics. This is just one way to think about it. What do robotics do for you before the procedure, during the procedure, and obviously how you execute the procedure as the surgeon is really important. This was one of the first robotic systems ever created. This is this incredible sci-fi look, but they don't look like that anymore. This is a picture of kind of more what we see now. Just advance one more. Yeah, so there's Think Surgical on here. There's Smith & Nephew has one called the Cory, no relation. Stryker Mako has a robotic system. DePuy came out with Velis. Zimmer and Biomet has a ROSA system. And there are others. OmniScience was acquired by Corin, and now that's called the Omnibot. Here's the key. If you take nothing else from what I say, we need to learn from yesterday, live for today, and hope for tomorrow. So we should never stop questioning. We should always try to be doing better and better. And I think robotics is right there at this point. I thought it might be cool, and I know I only have a few minutes to talk, but I thought it might be cool to look at this video to really show you how robotics works. So the picture you see down there in the bottom left is a 3D model of this individual patient. The green implants you could see are my initial plan. I do place pins into the bone. I place 2 pins into the tibia, and then you'll see me step around the table and 2 pins into the femur. These videos, by the way, will not get graphic. It just kind of gets the lay of the room. I attach these arrays because what I do with the arrays is connect that information to the preoperative CT scan. You know, I always tell people when you start with the CT scan, you're really starting with the truth, right? Not starting with a guess. So you'll see me use this probe, and I'll just take several dots on the femur here to teach the system exactly where the femur is in 3-dimensional space. I'll do the same thing on the tibia. Again, I'm using the CT scan that was done weeks ago and now correlating that to the anatomy in the operating room Osteophytes, that's a fancy word for bone spurs. So I take a second here to remove the bone spurs. These can affect the ligament laxity. And then I spend a lot of time at this step. And I really want you to understand robotics and the involvement of the surgeon in these platforms. Now I have to take all that information from the CT scan, and I use the individual information from the patient themselves during the case to really evaluate how tight or how loose. We've been talking about some patients battling with a lot of stiffness after surgery. So this is the most critical portion of the case for me. I'm using robotics as a tool, but it's really me with these specific types of techniques, trying to determine exactly how I can fit those components into the patient to make sure that I end with a perfectly balanced knee. If we make the knee too loose, it doesn't bend well. If we make it too tight, it doesn't bend well. Here you'll see me actually use the robotic arm. I'll pull this arm in, I'll pull the trigger and watch the saw blade go to the exact position of where I want to cut the bone. Then again, I am controlling the saw blade, but it's keeping me in that plane of the cut. We're talking about sub-millimeter precision with these robotic systems. Then I can tension the knee, right? So I've started my resections, but I want to see what effect that had on that patient's individual knee. So I place what we call this tensioner. I'm expanding those ligaments. Many of you suffering with arthritis probably have bow legs, or maybe your knees are knocked. We call those varus and valgus. So we can charge you a lot of money, but really it just means the knee's not in proper alignment. So I want to make sure when I put the knee in that when I end, it's tensioned properly. The ligaments are not too tight. They're not too loose. And so you see me make some micro adjustments here to the implants so that I can make sure and get the knee in there just exactly right. Just like I did on the tibia. You'll see me, this is just me making a few changes. You'll see me here in a second bring in the arm once again to make those cuts. Again, it's a precision way to execute your plan based first on the CT scan and then customized, obviously, for the patient. I don't know if we can spin that video forward just a little bit, just to show that the arm comes back in and makes there you go, femoral cuts. So the arm will come back in and make all the final cuts. Then we'll put the implants in, obviously close the patient, take those pins out, and off you go. Let's advance to the next slide. Now, I chose to kind of illustrate robotics based on the fact that, it's a knee replacement, of course, but the reality is that's the intraoperative workflow, but this can work for knee replacement or hip replacement. I thought it may be helpful if we just click through maybe one knee case here and one hip case. So that's the x-rays. This is the CT scan. Just keep going. I'll just talk as you go. This intraoperatively, I'm making some minor adjustments. Keep going. And ultimately, you end with the result, with the implants being in the proper position and the knee well balanced. Click through the next knee case. Just click until we get to the hip case. I just want to show you how that looks in the hip case as well. We'll end with this final hip case. So total hips, progressive right hip pain. Many of you are suffering just like this. Look at how advanced the arthritis is of this right hip. Click again. Not just x-rays, but now we can plan it out on the computer, or we can use a CT scan. One more click there. This is what one of the robotic platforms looks like. This is a 3D model of this individual patient. Keep going there, and you can see that I'm going to put these implants in. I'm going to plan it in 3-dimensional space. Keep going. I'm going to use this information. I'm going to ream the bone. That's the acetabular or the pelvis that I'm reaming. Keep going there, and I'm going to use this information on the femoral side as well. And ultimately, as we keep going through the slide deck, I'm going to end with a case that looks just like that. This is actually not an x-ray. This is what my plan is for the x-ray. And if we click just a couple of more clicks forward, you'll see that actually that one back now, you'll see that actually our final plan is exactly what we planned in robotic space. Advance to my last slide. So robotics I could talk about for about 17 hours. I won't torture you with all that, but the reality is Bone Smart has been incredible. I've loved the webinar today. I hope that this leads to a lot more connections, not only with me and my colleagues here, but I hope we can be of value to you as the patient. Thank you for your time.